everybody. My name is Dr. Chinonge. I thank you for this opportunity once more to share. I previously spoke on COVID-19 and its treatment, and today we'll be talking about COVID-19 and your lifestyle. COVID-19 and your lifestyle. I hope everyone can see my PowerPoint presentation. The reason why I chose this topic is that in our last discussion, I could, and also just generally personally for myself, is that during this time and also in our last discussion, I could get a sense of frustration that was coming through with the fact that, you know, we are feeling a lot like our autonomy has been taken away. You know, we are not able to, you know, when there's a lockdown, you know, we don't have a choice. When they want to vaccinate, they're almost taking away our choice as well. So there's a lot of frustration and anxiety that, you know, we are not in control of things. We've lost control of our autonomy, so to speak. So I wanted to talk about something that is within our control, something that we can do with regards to COVID-19. And that's how our lifestyle can impact in terms of COVID-19 and the outcomes of one, if you do get it, what the outcomes will be. So that's why I decided to talk on COVID-19 and your lifestyle. What essentially we will be discussing is that I'll just give a brief introduction. We'll look at some definitions, and then we'll look at some background in terms of lifestyle diseases, because that's really what we're going to be talking about. And then we'll look at some of the risk factors for severe disease and COVID-19. Cancer, metabolic syndrome, hypertension, and diabetes are the main things I've chosen. But there are a few others, which we'll get through. So I just want to move this. So just in terms of an introduction, what is a lifestyle disease? A lifestyle disease is essentially a medical condition or disorder regarded as being associated with the way in which a person lives, such as heart disease or obesity. So how does the way we live, how can we change the way we live that will impact the outcomes of COVID-19 is essentially another way of looking at it. So lifestyle diseases are things that we do that cause diseases in our lifestyles, yeah? And then we've got what is a comorbidity. So I've heard a lot about comorbidities. I think a lot of people never knew this word until COVID hit, and now everyone knows what it means. So it's a disease or a medical condition that is simultaneously present with another or others in a patient, or the simultaneous presence of two or more diseases or medical conditions in a patient. So if you've got more than one disease, you've got a comorbidity, okay? And then the third thing is a non-communicable disease, which is a medical condition or disease which by definition is non-infectious and cannot be passed from person to person. So COVID-19 is a communicable disease. TB is a communicable disease because you can communicate it, which is passing it on. And then things like cancer, hypertension, diabetes are not communicable because you can't pass it on to the next person. Although there might be a generational, hereditary component to it, but it's not something you can pass on to the next person. So that makes it non-communicable. All right. So just looking, I'm not going to go through the history of COVID-19 because I'm sure we're all aware of Wuhan and that it started there and then rapidly spread to the rest of the world. But here in South Africa, these stats were from Monday, which is about 3-4 days ago. We had 201 new cases, which has dropped significantly from what it was previously. The deaths are sitting at 88,000, and then positive cases is almost 3 million, and the recoveries are almost at 2.8 million. So, I mean, the question simply is, which I put in the next slide. So majority of people recover. So that's a fact with COVID. Most people that get COVID won't have to go to hospital. Most people that get COVID won't end up in ICU. majority of people that get COVID won't end up dead. So that's in terms of statistics. So about 90. So if you've got 100 people, 90 of the 100 people that get COVID, 90 of them, about approximately 90 of them, will recover at home without taking anything, without steaming, without steroids, without anything. 90% will generally recover at home fine, and there'll be 10% that will develop symptoms. Of the 10% that develop symptoms, only about 5% of those, so 5 people out of 100, will end up in hospital, and only less than half of them will then, about 2.5 of them might end up in ICU, and then a smaller fraction of them will end up, will demise. So yeah, that's the story of COVID. So the question is, we've got the 90%, but that 10, you don't want to be in the group of 10 that end up with symptoms, or in the group of 5 that, well, yeah, in the group of 5 that end up in hospital. So how can you avoid being part of that group, right? Besides vaccinating, of course. So what are the other means you can do to avoid being part of that group is really the question. So what determines if someone will get severe disease or not? So going back into lifestyle diseases. So the World Health Organization, I think it started in 1990. The World Health Organization in 1990 decided to come up with a study called the Global Burden of Diseases. Essentially, they wanted to look at the causes of illnesses, not necessarily deaths. The causes of illness is what makes people lose income, and then the causes of death, the leading causes of death. So they broke it down into countries, into income groups per country. So they put the income groups together, and then globally as well. So they were looking at causes of mortality, and also the leading causes of people to lose work or time at work. So I've got a table in front of us. So let me just read here. The burden of disease is a concept that was developed in the 1990s by the Harvard School of Public Health, the World Bank, and the World Health Organization to describe the death and loss of health due to disease, injuries, and risk factors for all regions of the world. And the reason why you'd want this is obviously so you can put in correct interventions to prevent these kinds of things. So if you know that malaria is the leading cause of death in Zambia, then you can easily put in public health interventions to decrease the number of deaths from malaria, and you know it's something that you have to do. But if you find that, let's say TB is the lowest on the list, then you put less money into TB and more money to the malaria. Those are the reasons why the World Bank is also involved, and the World Health Organization. So in 2004, so they do it about every 4 or 5 years, there's a new study that comes out, and basically what they do is when someone demises, us at the hospital, we need to document the death, and we need to give the cause of death, and that goes to the national level, and then national level reports it then to the World Health Organization. So every country does that, every structured country anyway. So they found in 2004, so it doesn't change that much every 4 years or so. It'll take some time to change the causes of death. But in 2004, I'll give you more relevant statistics soon. In 2004, the leading cause of death, as you can see, there is ischemic heart disease. So essentially that's blockage of the arteries, the blood vessels around the heart. It's the #1 cause of death in the whole world. So this is bringing the whole world together, looking at HIV, looking at TB, looking at malnutrition, diarrhea. So they looked at all the causes of death in the whole world. And ischemic heart disease, most people were dying from heart attacks than anything else in the world. And the second cause of death was cerebrovascular disease, which is essentially strokes. So the 2 leading causes of deaths are the risk factors for them essentially are lifestyle diseases, okay? So what causes ischemic heart disease? It'll primarily be diseases of lifestyle. So hypertension and diabetes are the leading causes of ischemic heart disease. So you can get other causes, that might not be non-communicable causes. So things like HIV, things like antiphospholipid syndrome can give you ischemic heart disease, but they're very rare. So what's common is high blood pressure and sugar diabetes and cholesterol. Those are the leading risk factors for ischemic heart disease. So essentially, we can see from this table, and so same thing with the stroke, because they're essentially just blockages in the arteries. So one is blockage in the arteries of the brain, the blood vessels in the brain, and one is blockages of the blood vessels around the heart, both causing death to tissues. So we can see from this that a lifestyle, the way we live our lives. So another way of putting it is to say that we're essentially killing ourselves as the world. And you know, the way we're living our lifestyles is leading to this type of death. So there's another table which I didn't add here that looks in terms of incomes of the country. So it will have high income countries where the main causes of death, the top 5 will be non-infectious. So they'll be basically related to non-communicable illnesses. So it'll be heart attacks, it'll be strokes, it'll be cancer, and it'll be COPD, which is related to smoking. Those are the main causes of death in first world country. And then if you come to third world countries, you'll find that maybe pneumonia will be number 2, but ischemic heart disease in a lot of third world countries is now number 1. And the fact of the matter is that because our lifestyles have changed, we've become more westernized in terms of our diets, in terms of our sedentary lifestyles, in terms of having conveniences. So that's led to us living the same kind of life as someone who's in a first world country. And therefore we're dying from the same things, essentially. And we see that in terms of percentage of total deaths, ischemic heart disease at 12.2%. Going down the list, cerebral vascular disease, 9.7% of total deaths. And HIV is only at number 6 if you look at the global picture, which a lot of people are surprised by. I did say this is 2004, but if you look, there's a 2015 and 2010 global burden of diseases, and it's the same causes of death in the same order, basically. And this is the most recent one. So this one broke it into age groups. So causes of death from 15 to 49 years of age in the world, and this is in 2017. And so it's within this age group. The number 1 cause of death between the ages of 15 and 49 is cardiovascular disease. So now they've combined the stroke, cerebral vascular, and the heart, the ischemic heart disease, and called it cardiovascular. Cardiovascular disease. So is the number 1 cause of death in people under the age of 49. So once again, it's a lifestyle thing. Number 2 is cancer, which majority of cancers are based on our lifestyle, particularly like smoking. Although there is a component that is genetic with cancer, so we can't deny that. But there's a link between lifestyle and cancer. So cancer is more prevalent in first world affluent countries than it is in poorer countries. One could argue maybe they look for it more in the first world, but that's a debate for another time. HIV and AIDS in this population group is coming out at number 3. In the older group between the ages of 50 and 69, we find that cardiovascular disease is still number 1. And then you've got cancers, which are, you can see the gap between the lifestyle diseases and the infectious diseases, which would be more your respiratory diseases. So if you combine the two, cardiovascular disease and cancer are still the predominant causes of death in the world. So there's a lot of work that still needs to be done, and a lot of this work is on ourselves. It's a lot of deaths are preventable deaths. It was just, maybe a lack of knowledge in terms of how to look after oneself, in terms of fitness, in terms of eating, and preventable, non-communicable diseases. So prior to COVID-19, there was a big concern about non-communicable diseases, and in fact, they were talking about a pandemic that is hitting the world in terms of non-communicable diseases that was essentially overwhelming us. And yeah, so it was looking at hypertension, diabetes, metabolic syndrome as well. And here we just have a graph showing us in terms of deaths, what's the leading cause. And there we see a large chunk of it is non-communicable diseases. It's almost about 50% of the deaths in the world are deaths that are preventable with lifestyle changes. So going now to the relationship with COVID-19. So the risk, what is severe disease? So we're saying risk factors for severe disease, but we need to know what is severe illness when it comes to COVID-19. So there's a general classification that is understood. So you've got your asymptomatic or pre-symptomatic patients. These are patients that are positive for COVID-19 on a test, but have no symptoms that are consistent with it. So it's just incidental findings. Then you've got mild illness, signs and symptoms of COVID-19, but no shortness of breath, dyspnea, or abnormal chest imaging. So that's the majority of patients would either fall into the asymptomatic or the mild illness. So that's the 90%. And then you've got your moderate illness, which shows signs and symptoms of low respiratory disease or abnormal imaging, but the oxygen in their blood is still above 94%. That's now the small 10%. They're symptomatic, but not too bad. And then your 5% that end up in hospital with the severe illness are those with the oxygen level of less than 94. So they need oxygen. That's why they get admitted to hospital. And they're essentially on room air, their oxygen levels are low. PF ratio is not important for us to know at this level. They're breathing very fast, they're tachypneic. And then if you do a chest x-ray, or a CT scan, the infiltrates are more than 50% of the lung. And then you've got critical illness, where essentially they need ICU. So you've got all these levels. So we wanna, if we get COVID, we wanna stay within the moderate and asymptomatic range. So we might get like flu-like symptoms, but not requiring hospital. So how can we avoid getting, or what are the risk factors of getting severe disease? Who gets severe disease and ends up in ICU? I'm going to mention some of the factors, but the fact of the matter is that particularly in the last wave, we saw a lot of younger people ending up in ICU, which goes against what we know. I mean, generally speaking, these risk factors hold, but there is a lot of younger people that we did see in ICU. There are others who are elderly but had no comorbid illnesses. They looked well, that did end up in ICU needing ventilation. Some did die. So as much as we may say that these are the risk factors, and if you don't have any of these, you're kind of safe, there is a randomness to it which we don't fully understand. I think it may have to do with the genetic component. I think there's a genetic component on whether you get severe disease or not with COVID-19. And I think comorbid illnesses play a role in it, in terms of changing your genes. I believe some young people are born with this genetic component, which maybe we'll discover in 10, 20 years' time. Some young people are born with this genetic component, and that's why they get severe disease, although they may not have any comorbid illnesses. I think the youngest patient we treated, except for the pregnant ones, the ones without any comorbidities, was, I think, 24, 28, yeah, somewhere there. Yeah, he required intubation, wasn't doing well. I don't know where he eventually ended up, but yeah, I think there's a genetic component, and I believe that lifestyle diseases kind of trigger that gene to severe disease. And the way it does that is that essentially when you've got these chronic illnesses, your body is in what is described as a chronic inflammatory state, because of the hypertension causing, so sort of causes inflammation because there's pressure against the walls of your blood vessels and sort of causes an inflammation in the walls. The same diabetes also causes that, and central obesity itself. So the adipose, particularly the central adipose, the brown adipose, also causes that kind of inflammatory condition, and it's thought that that might be what predisposes people to severe COVID, because what causes the severe COVID is also just inflammation. There's a buildup of inflammation in the body. I didn't go through the pathophysiology. I don't think at this level we need to know the intricacies of that. So these are the risk factors for severe disease. So age is vital. So age without any comorbidities, we saw a lot of that. So there were plenty of 69-year-olds with no chronic illnesses, but ended up on a ventilator. So there was a study, this is from the CDC, sorry, it's not a study, and they note that older adults are more likely to get severely ill from COVID-19. More than 80% of COVID-19 deaths occur in people over the age of 65. Yeah, 80% of COVID deaths. So majority of people that are dying from COVID are people over the age of 65. And more than 95% of COVID-19 deaths occur in people older than 45, 95%. So you're kind of safe if you're younger than 45. In the UK, the stats are even more leaned towards older age. I think theirs is like people above the age of 75. The majority, like 90% of their deaths from COVID were people over the age of 75. I was quite impressed with that. I was like, wow, for a nation to lock down for retired people was quite impressive, because they had basically no deaths in people under the age of 40. But they locked down the whole the whole country. They stopped economic activity, even for those who are in the prime of their economic activity, for the sake of those above the age of 75. And Boris Johnson came out to say, we won't be leaving anybody behind. And yeah, essentially the healthcare system can do that, and the economy can survive that. Another risk factor is chronic kidney disease. So those with chronic kidney disease, and we saw plenty of them, people with chronic kidney disease did not do well in ICU. I can't remember one that actually survived here in our institution. They just didn't respond well. And that's also chronic inflammatory state that they have. And then chronic lung disease, COPD, asthma, bronchiectasis, anyone that's got a chronic lung disease is at high risk for severe disease. Obesity, overweight people, so BMIs above 25 are at high risk for severe disease. Often in the second wave, yeah, I've gone through all the waves, sure. Yeah, waiting for the fourth one, sure, I'm tired. In the second wave, we found these are all anecdotal, but there were quite a number of people between the ages of 30 and 45 that ended up with severe disease. No comorbid illnesses, they just had that pot belly, that was it. But fortunately, most of them survived. I think because of their age, most of them actually did make it out of ICU. But yeah, it was a battle. Pregnancy, in the third wave pregnancy, we saw a lot of pregnant women who didn't do well. The pregnant ladies, none of them survived. When I spoke to the doctors in California, the experience as well was that the pregnant ladies actually did very badly with it. Why is that? Pregnancy is that pregnancy itself decreases your immune system. Then liver disease, liver disease, it's a difficult one because liver disease in its own, the prognosis is not great. Hypertension, many people only had hypertension as a comorbid illness, ended up in ICU. Then you've got heart disease, and then diabetes, type 1 and type 2, and then HIV, okay. So the risk factors were continuing, just a little bit on cancer and the experience that others had with cancer. So approximately 8.4% of deaths in New York City from COVID-19 were people living with cancer. So about 10% of the people that died already had cancer. Studies from China and Italy also found increased death rates amongst patients with cancer. And then in one New York City center that was treating 2,000 cancer patients, 423 of those patients developed symptomatic COVID. 40% of them required hospitalization. So that's almost 50% of those that did get COVID, which is very high. 20% developed severe disease. Remember, I said 10% generally in the global population. And then 12% died. That's also a high mortality. So The mortality we know is probably less than 1% in terms of COVID. That's globally, but we'll only find out later properly. So cancer is a high risk, any type of cancer, because that also weakens your immune system. You're not eating well. So yeah, you're at high risk of severe disease if you are to get COVID when you have cancer. And then you've got hypertension. So there was a study done in China which showed a mortality rate of 6%. So it's less than cancer with patients with hypertension that develop COVID. The reason why the mortality rate is or why they don't do well, it's postulated that there's a physiological process that happens in the body when you've got hypertension, and basically your ACE2 receptors get upregulated. And ACE2 receptors are the receptors in the lungs that COVID attaches to and gets into the cells. So if they get upregulated, then more virus it's not cancer, more virus can get into your cells, and then you get severe disease. Okay, so it's postulated, but yeah, not confirmed. So there have been there's been no evidence that hypertensives are at increased risk of contracting COVID. So they might be at increased risk of getting severe disease, but not that they'll get COVID. They're more likely to get COVID than anybody else. And then in terms of diabetes, so in 1985, we had 30 million people who were suffering from diabetes. In 2010, that went up to 285 million people globally that were affected. In 2019, which is the last real numbers that we have, the number was sitting at 463 million people in the world have got diabetes. So if you've got diabetes, you're in good company. There are a lot of people in the world that have got a type 1, type 2, type 3. So diabetes is the leading cause of end-stage renal disease. It's the leading cause of adult onset blindness, and it's the leading cause of non-traumatic low extremity amputations. The prevalence of diabetes amongst COVID-19 patients is thought to be in the range of 10 to 15%. So if you have a group of 100 people with COVID, about 10 to 15% of them will have diabetes. What we often found is that patients that came in maybe with just one comorbid illness of hypertension, we often found that they came in with high sugar levels. Those who already had diabetes came in with a diabetic ketoacidosis or hyposmolar non-ketotic acidosis. And the theory of why, particularly when they have an infection or why they have COVID, that their sugars, patients' sugars shot up, was that it's believed that the pancreas may have ACE receptors as well, and the virus can actually go into the pancreas and it disrupts the functioning of the pancreas and releasing insulin, and then that's why the sugar levels actually go up. There's a study which, yeah, it's a good study if you're into public health and if you're into medicine, the ACOS study. That was a multi-international study done in Africa, for Africa, yeah, decolonizing. It was done in Africa. They were looking at tertiary institutions around Africa, so South Africa, Egypt, I think it was Nigeria, Ghana. There were 5, 6 other countries that were involved. And in South Africa, it was University of Pretoria, Steve Biko, and Grooteskeer, and I think it was Joburg Gen as well, that were involved in the study. And essentially what they wanted to do is that the Europeans and the South Americans and the Asians had all done studies in terms of ICU outcomes. So patients that are admitted into ICU with COVID, how many of them actually survive? And most of them were ranging around 25% mortality rate. So 75% of people that get into your ICU demise. So I wanted to look in terms of Africa, what is the outcomes? And they found that approximately 50% of people that get into ICU actually demise. And 50% survive. I think that's actually, and they're under recording because the study may have been done during a time when we were not having a wave. So if I was to do the study now, when we're not in a wave, the outcomes then improve because there are fewer patients, resources can be more directed to those patients, people are less tired, and these are some of the reasons why the outcomes are so poor. So yeah, 50% officially is the mortality rate in ICUs in Africa, which is double that of the other continents, double that, yeah, let that sink in. So yeah, we're not doing well. So the ACOS study showed that diabetes is an independent risk factor for mortality in ICU. So they also looked at some of the risk factors for mortality in ICU. And then people with diabetes have a COVID-19 mortality rate estimated at 7.3, which is more than 3 times that of the overall population in the world. Okay, I'm sorry, I just want to get this out of the way. Next slide. Right, so let's talk a little bit about metabolic syndrome, which previously used to be referred to as syndrome X. A syndrome is essentially a cluster of signs and symptoms that are put together, and it makes up a syndrome. So it's more than one thing that is put together. So metabolic syndrome is has got these features: increased waist circumference or belly fat. High triglycerides are fats, a type of fat. Elevated blood pressure, not necessarily high blood sugar, but what we refer to as insulin resistance. So your sugar might not be sky high, but it's within the range of almost becoming diabetic, pre-diabetic, we also call it, and a low HDL. So you don't have good cholesterol. HDL is good cholesterol. You've got bad cholesterol, which is the triglycerides. Your sugar levels are almost in the diabetic range. You've got blood pressure problems. You've got the pot belly, which previously used to be looked upon as a sign of affluence amongst the tenderpreneurs, but now we realize it's a sign of illness. So why is metabolic syndrome such an important thing to talk about and discuss? Is that it's related to essentially all the non-communicable diseases that we're talking about. I'll go into that now. So these are just some random numbers. So about 85% of people who have type 2 diabetes also have metabolic syndrome. So it's 3 of one of the things I mentioned. So if you have any 3 of abdominal obesity, high blood pressure, high blood sugar, high blood pressure, triglyceride levels that are elevated, and a low HDL, or good cholesterol, any 3 of them, and you've got metabolic syndrome, and that makes you at high risk of developing diabetes. And you've already got hypertension, you've got diabetes, and now you'll be overweight. So your risk of having a heart attack jumps up, your risk of having a stroke jumps up. And then we also know now that your risk of severe COVID also is quite high. Now, if you've got high blood pressure and sugar, then the risk is high. So this is what we have just been, it's been our bread and butter in terms of COVID patients in ICU. I remember my colleague during the first wave, and she was just shocked, and she was like, they all look the same, meaning the patients, like, they're all the same phenotype in terms of the body. Everyone is was just having the central obesity. If you looked at their comorbid illnesses, high blood pressure, sugar, diabetes, and that was just like almost all the patients we saw was that. And then once in a while, we'd see something in between. So it is a significant risk factor for severe COVID. And then there's some studies that have been done, basically showing the hazard ratio is basically looking at exposure and seeing if this exposure leads to increased mortality. So over years, if you've got metabolic syndrome, your risk of dying increases compared to the control, those who don't have it. And we see it's about 3 times. The risk of dying when you've got metabolic syndrome is about 3.5 times more than someone who does not have metabolic syndrome. And this is dying from something else than COVID. Okay, and then this is mortality associated with metabolic syndrome. It's a nice slide if you've got time to read it. Essentially, what we have is that if you have had a cardiovascular disease, so if you've had a stroke or heart attack and you've got diabetes, your risk of death is there, 44.1 deaths per 100,000. Per thousand, sorry, which is very high, actually. It's very high. And then we see that if you've only had cerebral vascular disease, then your mortality rates goes down. So diabetes itself is quite a strong risk factor for death, generally speaking, yeah. Okay, so now I just wanted to move into some of the things we can do now to take control of the situation. So we know that, okay, if I'm overweight, if I've got high blood pressure, if I've got sugar diabetes, my risk of death is high. So what can I do about it? So there are various means one can use, and a lifestyle means. So because we're saying these are lifestyle diseases, so we've got these illnesses out of choice, the way we've lived our lives. So obviously I'm generalizing. There will be a few people who it's just a genetic component, but those are minority. Don't think yourself a minority. Those are the smallest numbers. So let's generalize. You're part of the general population as an individual who may be suffering from these illnesses. So there are certain lifestyle things. So you can look at the things that affect us having metabolic syndrome or having hypertension and diabetes is one is lifestyle things. So exercise, your diet, and there's a third one that I've now just forgotten, but we'll get to it anyway. So the first thing I wanted to look at is in terms of diet. Okay, so this is a famous study, a DASH study. So a lot of guidelines, hypertensive guidelines, American, South African, have based their dietary recommendations for hypertensives based on this DASH study that was done in 1997. So essentially what they did was they enrolled 459 adults with high blood pressure, so systolic blood pressure of over 160 and diastolic over 80. And then for 3 weeks, as a control, to get them all on the same level, because they may have been eating differently. For 3 weeks, they fed them the same diet, which they called a control diet, which was low in fruits and vegetables and in dairy products, with the fat content typical of the average diet in the United States. So it must be very high. So high fat, low everything else. That's which is the basic diet of first world countries. So this was the control. For 3 weeks. You're going to eat like a normal person, so that we get all of you deranged in terms of your metabolics, and then they split them out into 3 groups. So they randomly assign them. So they assign them for 8 weeks, which is 2 months, on either the control diet, which was just the fat, high fat, or they put them on a diet rich in fruits and vegetables, just fruits and vegetables, or a combination diet. So this diet was essentially rich in fruits and vegetables, and then they had a low fat. So a low fat dairy products and with reduced saturated and total fat. And then the sodium intake was the same, and then they had to maintain the same body weights. And what they essentially found was actually the combination diet with low fat. The low fat diet actually did very well. So that would be the one that dropped here at the bottom. So those are the low fat in terms of the systolic and diastolic. So this is just on diet alone. So they maintain their medication, they maintain their body weights, they maintain their sodium intake, and on diet alone, you can drop your blood pressure from like 132 to 124 in terms of systolic. What impressed me and why I put this here was the duration. If you look at the bottom here, this is the number of weeks, and within 2 weeks there was already an effect just on the diet alone. Within 2 weeks. So it's not necessarily that when I change my diet, it's going to take forever and to improve. But just on diet alone, 2 weeks time, you can see a difference in terms of your blood pressure. So this is the DASH diet. In terms of what diet is the best diet, it's still controversial. I know some Adventists would want me to say vegan diet, but it's in terms of the scientific world, it's still controversial. The feeling is that it doesn't matter which diet you're on. What matters is the consistency. So the thought is that any diet can make you lose weight and essentially drop your blood pressure. But how consistent are you going to be with it? And the diets that they do recommend are diets low in fat, low in carbohydrates. So Chinonge's diet or Benting diet or a plant-based diet. it needs to be something that you'll be able to do for a long time, for the rest of your life, because you don't want to go back on it. I tend to find that the Banting and the Noakes diet are quite, they seem very hectic. People do lose significant weight, but in the long term, those diets haven't actually been studied. So we don't know what complications could arise from having a high ketotic diet. Mediterranean diet, DASH diet, plant-based diet, those are essentially the traditional diets that we know are healthy, that are good for losing weight and for decreasing blood pressure. In terms of exercise, so this is a study, I think I got it from the Lancet, if I'm not mistaken. And it essentially showed that isometric is isometric exercise. I'll tell you now, it's things like yoga, stretching. We're just stretching your muscles. So isometric exercise training for blood pressure management. So they wanted to see what the effects were. And the conclusion was that isometric resistance training lowers systolic and diastolic blood pressures and mean arterial pressures. And the magnitude of the effect is larger than that previously reported in dynamic aerobic or resistance training. So just isometric type of exercise actually drops your blood pressure. They are suggesting more than swimming and running and cycling. And they're saying our data suggests that this form of training has the potential to produce significant and clinically meaningful blood pressure reductions and could serve as an adjunctive exercise modality. So exercise itself alone, without anything else, without even you changing your diet, can make you lose weight and also control your blood pressure. The thought is that, your output should be more than your input. If your input is more than your output, then the food you have eaten needs to be stored somewhere else because you haven't used it as energy. So if you increase the amount of energy you use up, then you lose weight because you're using up the energy that you put in, and more because your body can also produce energy of itself, and you lose weight as your body produces that energy. And then this was just on aerobic exercise, and the study showed that aerobic exercise reduces blood pressure in resistant hypertension. So resistant hypertension is essentially if you're on four agents or more, and one of them must be a diuretic, then you're resistant. There's the old patients who just add medication, and it's just like, I'm not touching this blood pressure. It's 180 over 110, and you're adding another drug, and eventually you're sitting at 6 agents, and you don't understand. You think maybe the patient's not taking their medication or something. And another modality that you can prescribe to them is actually aerobic exercise. So it doesn't just work for patients who are like borderline hypertensive, but even those who've got severely high blood pressures. Obviously, they need to be cautious in terms of as they exercise, they don't want their blood pressures to actually go up too high. All right, so this is from the South African Hypertensive Guidelines published in 2015 or so, 2015, 2016. And so these are their recommendations, lifestyle changes. So they encourage the first step, it's a stepwise process. Their first step is actually lifestyle changes, and then they actually recommend, then you add one agent drug, and then you add a second agent. So they look at weight reduction is the first thing. So you need to target a BMI of between 18 and 25. And they give you values of how much you can actually drop your blood pressure by. So it's 5 to 20 millimeters of mercury per 10 kilograms. So if it was 60 to go to 150 per 10 kgs that you lose. They advocate for a DASH diet. They feel it's sustainable. Patients are more likely to stick with it, which is low in saturated fat and total fat and high in fruits and vegetables. So that can drop your blood pressure between 8 and 14. And these are independent things. So it's not that your blood pressure won't drop if you only do the diet. So independently, you can drop your blood pressure. So if you put them together, you get a significant drop in blood pressure. You decrease your dietary sodium to 6 grams per day. Increase physical activity, brisk walking for 30 minutes per day, most days. So they say 5 to 7 days in a week. You can drop it 4.4 to 9. And then moderation of alcohol. Well, yeah, I would say no alcohol. Alcohol is bad, 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 bad. bad. Yeah, alcohol is just a destroyer. Just a quick note, we're almost coming to an end of our talk. There's just one last thing I wanted to discuss, which I'll mention at the end after this glucose brief. So just an idea of what diabetes is. Diabetes is essentially, the key is your insulin. So insulin is produced by the pancreas. It allows the cell to access the glucose that you get from eating or that you break down in your liver to produce sugar. And the insulin basically unlocks with the key there of the cell. It's a key of the cell, so that the sugar can go in and give energy to the cell. These are the symptoms of diabetes, essentially. Frequent urination, excessive thirst, increased hunger, weight loss, tiredness, lack of interest and concentration, numbness of the hands and feet, blurred visions, frequent infections. If you're experiencing these and a few others, then you can go see your doctor. In terms of the definition of diabetes, fasting blood glucose above 7 or an HbA1c of above 6.5. And then you've got pre-diabetics, which are almost an in-between between a healthy sugar and the diabetes. Diabetes has got microvascular and macrovascular effects. We've already mentioned it can affect the kidneys, your feet, the heart. It can give you strokes, it can give you blindness, and reduce blood flow to the rest of the body. Some of the lifestyle changes for diabetes. So yeah, let me talk about this and then I'll bring up something else. So some of the lifestyle changes, so increased intake of fruits and vegetables, but you need to be cautious as a diabetic in terms of your fruits, which fruits you take, incorporation of regular exercise into your lifestyle. So exercise helps you maintain a steady sugar level. So diabetics should actually exercise, type 1 and type 2. And obviously, if you are exercising and you lose weight, you can actually reduce your, if you're on insulin, you can reduce your insulin requirements. If you're on metformin or oral treatment, you can reduce those requirements as well by losing weight with exercise. Minimize intake of foods containing simple sugars and saturated fats. If you gain more weight, you develop more insulin resistance. So as I showed here, that the key is insulin. So there are two types of diabetes, there's type 1 and type 2. So type 2, essentially, the problem is not with the key, the problem is here with the lock. So it's insulin resistance, the lock can't go into the key. In type 1 diabetes, the problem is with the pancreas and you can't produce enough, or you can't produce insulin that unlocks the cell. All right. And then stop smoking. All right, those are the questions. I just wanted to make just a quick note on losing weight, which I know a lot of people struggle with. So the steps to losing weight, it's very good to try and do it with a healthcare worker, because then they can advise when to start medication, if you need the medication, when you might need surgery and all those kinds of things, and looking at complications. So you need, it needs a comprehensive lifestyle intervention. So it's behavioral change, it's exercise, and it's diet. In terms of behavioral change, the quantities of food that's eaten, the type of food that's eaten, getting into habits of exercising. So your habits need to change. So that needs some kind of therapy, some kind of talking to. Then you've got dietary therapy, which we already mentioned, the different types: DASH diet, plant-based diet, or a Mediterranean diet, which tend to lower, which tend to help you lose weight. So it needs to be something that's sustainable. And then exercise, we mentioned 30 minutes, at least 5 to 7 times a day. And then after that, then there's other steps that we can take as healthcare workers. If all of those are failing, or if your BMI is above 40, it'll be quite difficult for you now to start exercising when you can't even walk. So yeah, that's essentially it. I think I'll hand over then to Connie.